Chapter 28, Musculoskeletal Trauma. So this chapter begins to introduce some of the concepts having to do specific with the musculoskeletal system, things such as breaks and fractures, tears and strains and sprains and everything else. These types of injuries are things that we tend to see mostly with falls, once in a while from something like a car accident, but more often than not we're going to get these from sporting injuries or other activity-induced injuries. The basic review of the anatomy for the musculoskeletal system, it includes the bones, the joints, the muscles, cartilage, ligaments, and tendons. So collectively, all those things make up that musculoskeletal system. And what we need to understand is that when one thing is injured, there's a high likelihood that one of those other components is injured as well. So for instance, if we break a bone, yes, we have to be worried about the bone itself and the bleeding and the pain that could ensue from that, but we're also more than likely going to have at least some type of small tear associated with the connective tissues, being either a tendon or a ligament within that same general area. So the bones are relatively dense. They are formed of multiple connective tissues. And something to keep in mind here is that over time, the bones harden, right? So a small young child, an infant, their bones are still relatively soft and pliable. Over time, the bones start to harden up. And then ironically, toward the end of life, as people approach their elderly years, the bones actually start to become more brittle. So what that means is that early on in life, with these small children, these infants, it is extremely difficult to break a bone. Reason being because they are soft and pliable. These bones tend to bend more so than anything else. When we do come across a trauma with a small child that involves a break, we should be really kind of looking at the potential for this being abuse related or a very significant mechanism of injury that caused the break. Kids who fall off a couch, kids who trip and fall, they usually don't fall and break a bone. Okay, they may hurt themselves for sure. They'll have some bruising perhaps, but rarely is it actually going to break a bone unless there's some type of underlying medical condition. As adults, our bones are a little bit more resilient because they're hardened, but it's still a potential for us to break those bones if the impact is great enough. But then as we move on to the elderly patients, because their bones have become so brittle, they fall and break them very easily. So a simple fall from a standing position can result in dislocations, bone fractures, or even tears and strains. So our trauma patients in the elderly, those are typically going to be far more susceptible to injury, and we're going to have to really do a good, very detailed head-to-toe assessment to identify the presence of any of those injuries. So looking here at the bones in the general diagram, remember that this is stuff that we reviewed all the way back at the beginning of the semester. You're certainly going to want to be able to label this diagram if you had to, so make sure that you're reviewing all this and you've got these things memorized. There's several different shapes that bones are classified into. As stated here, irregular, long, short, and flat, and those bones are existing throughout the entire body. From a trauma perspective, not a lot for us to really be overly concerned about. We're going to splint wherever we can splint. We're going to immobilize wherever we're going to immobilize, and it really doesn't make a difference what classification of shape the bone would fall into. But you do have some examples here. You know, the scapula is probably the most prominent example of a flat bone there, right? Something that we see on a regular basis. We can actually feel that on the outside of the body. We've got the vertebrae that would represent irregularly shaped bones. We've got flat bones such as the ribs, and then you've got your short bones and long bones that are illustrated there. The longest bone in the body is going to be your femur in the leg, and ironically, it's also one of the most vascular. And as a result, if we break a femur, we have the potential for quite a bit of bleeding within that area. We'll talk about that more later. The great thing is about bones, because they are comprised of just a bunch of tissue, they're able to regenerate and they're able to heal themselves. And as long as the bone is properly set in place over a long period of time, it'll start that healing process, and there's a high likelihood it's going to go back to the way it was prior to the injury. However, people who choose not to have their bones set, not to put in cast and everything else, there's the potential for it to heal abnormally. And that's something we want to ask about, especially with elderly patients. You know, if we find deformities, a lot of times that could be from a pre-existing issue. So no different than asking about a baseline mental status for the patient, we should also consider asking about, you know, do they have any pre-existing deformities or injuries that have not fully healed. We also have several different types of muscles. We've got skeletal, smooth, and cardiac muscle. Remember that the cardiac muscle is only going to be found in the heart. Skeletal and smooth muscle can be found generally throughout the rest of the body. Now, when we think about voluntary movement, we're thinking about skeletal motion. So if I were to lift something up and move it, if I want to simply stand up, walk, jump, run, anything like that, those are all skeletal muscles that are being utilized there. The smooth muscle is involuntary, and that's the muscle that wraps around the blood vessels. It's used in digestion, moving food throughout the intestines. So smooth muscle is generally inside the body, and it's all stuff that works on an automatic basis. The body just has processes in place that stimulate that muscle and make that muscle work. But more often than not, we need to consciously think about utilization of the skeletal muscle. And then the cartilage, it helps with the flexibility there. It allows the bones to come together. It helps to pad areas within the joints and generally allows for the movement of bones. Tendons will connect your muscles to the bones. Tendons will allow for muscles to be attached to the bones, and even from time to time you'll see them attached somewhat to a ligament. Ligaments then actually attach bone to bone. So across a joint you'll have a ligament that stretches from one bone to another bone, and that helps keep things in place. It acts kind of as a retention or a rubber band that keeps everything where it needs to be, but still allows for that flexibility for movement. So here's just an illustration of the three different types of muscle. And then here we've got some illustrations of how everything attaches. So you'll see here that the ligaments are attaching bone to bone, and it's stretching across the joint there. Keeps everything tight, keeps everything in place, but still allows for that movement. You've got cartilage that's going to sit in the middle here. That's going to offer some level of padding. And then the tendon connects the muscle itself down to the bone. And again, from time to time, you'll even see it connect a little bit to some ligaments. So general guidelines for emergency care when we're dealing with musculoskeletal injuries. The big thing here is looking at mechanism of injury. So while we can typically identify the presence of a deformity by looking at the body or palpating the body, sometimes pain will clue us in as to where an injury might exist. We're really thinking about this more from a mechanism of injury perspective here. So we want to think about what happened, what was the force, the physics behind this, and what could be some underlying injuries that we may be missing. Case in point being pelvic fractures. If my patient is unresponsive and unable to clue me into pain, it's going to be very difficult for me to assess a small pelvic fracture. I might be able to identify some crepitus or instability when I go to palpate that area, but generally speaking, it's really what we consider to be a hidden injury. And the problem there is that even the signs of internal bleeding resulting from that injury are not going to be obvious. And the patient has the potential to lose enough blood into the pelvic girdle there to actually put them into shock. And there may be no obvious outside indications to that. So that's where I need to be able to utilize my mechanism of injury and say, okay, this patient was involved in a car collision at 50 miles per hour. There's damage to the driver's compartment here, and the area of the impact is right around where their hips would be or their pelvis. I have to suspect the possibility of a pelvic injury. Same thing with falls and everything else. So looking at the different types of mechanism that could exist, we talk about here direct force, indirect force, or even twisting. And direct is going to be exactly what it sounds. If I were to punch a wall with my fist, the area of direct force is going to be right there at my fist, at my hands, right? It's going to involve my fingers, my knuckles, my hand, and maybe even my wrist. Now, the indirect force, though, is the energy as my fist impacts that wall, the energy is transferred up my arm. So I could actually have fractures maybe to the radius or ulna. Maybe it's all the way up to the humerus. I could even have a dislocation at the humeral head there with that ball and socket joint in my shoulder. So there's a lot of potential there. So I need to focus not just on the area of impact, but also anywhere else that energy may have been transferred. The twisting or rotational force, this is relatively uncommon, especially to have a twisting related fracture or break, but this is something that we tend to see potentially with abuse situations. But from time to time, my kid likes to swing around. He jumps out of the truck, and I hold on to his arms all the time just to prevent him from falling. if he were to jump and try to twist while I'm holding onto his arm to try to protect him, depending on how he landed or something, there's that potential for that break to exist. So just because it exists doesn't mean that it's abuse, but we certainly have to have that heightened index of suspicion. The definition of a fracture is going to be any break in a bone, open or closed. And a fracture could be just something as small as a small hairline fracture. And then you also see that they've got different definitions for types of fractures. Um, Whenever we have a comminuted injury or a fracture, that's going to be one of our biggest challenges. Because of those multiple breaks there, it's very difficult for us to pull traction, to get any type of alignment. It's going to be very painful, and the potential for quite a bit of bleeding also exists. Green stick fractures are probably some of the most common that we come across. These are ones where people, they complain of pain. Maybe there's some bruising or even swelling as a result of the impact. But generally speaking, there's no huge deformity there. These patients, maybe if they have a broken leg, can still walk on it. If they have a broken arm, they still make it work. And it's not until they actually go in and get an x-ray that they realize that there's a fracture there. Angulated, those are the ones that, if we were to take a long bone and snap it in half, that's what that describes. Now with these, we're going to probably find a pretty obvious deformity, right? There's going to be a large bump under the skin from where the bone is protruding. And from time to time, these may even break through the skin, causing an open fracture. So these should be easy to identify. Usually they are easier to pull traction and try to get a good splint in there. So there you go. There's an angulated fracture, right? It's very, very clear that the bone is snapped there. And I'll be honest with you, it says here closed fracture. Just based on the location here, I almost wonder if that wouldn't be more of a dislocation. But from our perspective, it's going to be difficult for us to really identify it. But you see a very profound outline here where the bone is at. Because the skin has not broken, we still consider this to be a closed injury. But if that were to break through the skin, we'd call it an open fracture at that point. We also have the potential for dislocations, which is just simply where something has been removed from a joint the way it's supposed to be. Sprains are going to involve ligaments. So if we were to sprain our ankle, we're actually talking about the ligaments that hold our leg bones into our foot and everything else. Strains involve muscles and typically involve just a basic overexertion. These things will heal on their own over time. The problem is anytime we have a tear of a ligament or even a strain or a tear of a muscle, there's bleeding involved. It's going to have pain, obviously. There's going to be swelling that ensues, maybe even some bruising from time to time. So these are going to be very painful injuries for patients. Clearly, though, they're going to be non-life-threatening. So since we can't really identify what is and is not a fracture in the field, because we don't have the ability to perform x-rays, CTs, or anything else, it's always important that we transport our patients into the hospital for further evaluation. And there's going to be a lot of times, especially with a car accident or maybe even a sporting injury, where somebody, they feel pain, they have some swelling, it could be broken, but we're not really sure. Maybe in the event of a high school football game, mom and dad say, no, we'll take them in later on if we feel like we need to, but we don't want them to go by hospital. And that's acceptable. Obviously, with any refusal of care, we want to make sure that they're fully aware of all the risks, they're well informed, they sign the appropriate paperwork, and we need to run that by medical control. It's really not the end of the world if somebody wants to transport themselves with most of these injuries. The assessment of musculoskeletal, obviously with any type of trauma assessment and any assessment in general, rapid identification of life-threatening injuries. Now keep in mind here that a lot of musculoskeletal trauma may not necessarily be life-threatening at all. I could snap my leg in half and it's going to hurt and it's going to seem like the end of the world, but at the end of the day, it's truly not a life threat. What we have to do, though, is avoid this tunnel vision. The musculoskeletal trauma, especially involving soft tissues where the tissue is torn and open, we have bleeding or gross deformities, those things are going to be very distracting to us. So we want to, although we need to identify them, because they're typically not going to be life threats, we don't want to avoid caring for life-threatening hemorrhage, airway or breathing issues, that type of stuff. That's going to be a higher priority. The swelling that's going to come into play is a lot of times going to make it difficult for us to really assess whether or not there is or is not a fracture there. But keep in mind that if there's enough swelling that we could probably assume that there's going to be a fracture beneath it. The other challenge with swelling is that as it continues to swell and apply pressure, it can cause what's called compartment syndrome. And compartment syndrome, what it does is it essentially acts as an internal tourniquet, right? It compartmentalizes an area, it prevents blood flow in or out, and as a result, we resort to the anaerobic metabolism in that region. And as we all know, the byproduct of anaerobic metabolism is going to be the pyuric or the lactic acids. So we have to be aware of that stuff. Not much we can do in the field pre-hospital, but simply recognizing these injuries and ensuring that we pass it along to the hospital is going to be important there. So with the progression of compartment syndrome, cellular damage is going to occur because of the lack of oxygen getting there and the inability to remove the carbon dioxide products. Anytime that we go to restore perfusion, we risk potentially rushing the rest of the body with all those acids that are built up in there, and we could have some cardiac issues from that. Generally, as we assess our trauma patients, and this goes really with anybody, we're looking for what we refer to as DCAP BTLS, right? Deformities, contusions, abrasions, burns or punctures, tenderness, laceration, or swelling. And with that stuff, everything in here kind of falls into those that region. As we talk about pain and tenderness, that can really be caused from anything. A simple bruise could be painful or tender, all the way down to a large fracture. Deformities and angulations typically involve the skeletal system. Grating, so that's crepitus, and this is actually it's a really nasty feeling. As bone is rubbing on bone and kind of like grinding against itself, you can feel it. It's a very obvious sensation. You'll know when you hear it, you'll know when you feel it, and that's obviously an indication of two broken bone ends that are rubbing against each other. Swelling and bruising can be caused by just about anything. Obviously, if we have an exposed bone end, that makes our job pretty simple to identify the injury. Joints locked into position. I don't see this very often at all, but there are times where something could lock up, especially if there's an issue with the ligament that helps to keep that joint moving. Nerve, blood, vessel compromise. We'll see this from time to time based on large fractures. We could see it from that compartment syndrome. We could even see it from a penetrating trauma, right? A stab wound, gunshot wound, whatever, that would interrupt one of those things. And then the compartment syndrome just can result from any of those things really coming into play. 6 P's of assessment. Other than this slide, I've never seen this anywhere else before. This is not something that anybody actually uses in the field, so I wouldn't even really be too concerned about it. Patient care. Take standard precautions. Sometimes I feel like a broken record talking about these things, but there's a reason that it comes up repeatedly in every single discussion we have. We just want to make sure that that is ingrained into your head. We always need to make sure that we're taking the standard precautions, utilizing the appropriate PPE, and ensuring our safety and the safety of our patients. From there, then, the primary assessment. We don't want these traumas to distract us from taking care of the ABCs. And then during the secondary assessment, if we do suspect the possibility of a spinal cord injury, even if it's just based strictly on mechanism of injury, we can put that collar in place. We want to do that as we're moving down and doing our head-to-toe assessment, because as the patient wants to move around or kind of observe their surroundings, there's the potential for them to move the head. Of point, this is actually an exam question. The purpose of putting on a C-collar is not to eliminate movement. It's not to prevent a patient from moving their head whatsoever. Even with a properly placed C-collar, the patient still has the ability to move their head around. What it does is it acts as a reminder to the patient and to the EMS crew that, hey, there's a potential injury here. Let's not move it unnecessarily. And since the patient has some level of resistance when they do try to move their head left to right, it's a reminder to them, oh, hey, I could have an injury. Let's hold still. But if they really wanted to move it, they could overcome the pressure of the C-collar, and they could certainly move their head if needed. As we identify injuries specific to deformities that would indicate a break or a fracture, we could certainly splint, but keep in mind that most of these are not life-threatening. So if you're spending a lot of time splinting on scene for a multi-system trauma patient, you're spending too much time. Splints can a lot of times be done in the back of the ambulance for our more critical patients. However, if you have a child that fell off a horse and they have an isolated arm injury, and there's a fracture to the humerus, let's say. Yeah, this kid isn't going to die from it. They're hemodynamically stable. They're perfusing just fine. Airway and breathing is all intact. Let's take the time to splint this thing appropriately and try to reduce pain and everything else when we go to move the kid. If we have open wounds, we're going to dress them as necessary. The advantages of splinting, and I talked last chapter about splinting being kind of a little bit of a waste of time, and we have to look at that objectively. There are certainly going to be advantages to splinting. However, based on our proximity to the hospital, if we're going to have a 5-minute transport and spend 7 to 10 minutes splinting, then are we really doing our patient any good? So it's just something to think about. It's not a black or white answer. You have to evaluate each situation. But if we do decide to splint, there are some advantages that come along with it. Obviously, by minimizing movement, it's going to help to reduce pain, reduce further injury. It's going to help with blood loss from time to time. So the bones themselves are actually very vascular, and there's a whole bunch of capillary endings that penetrate into the bones themselves. And as that bone fracture occurs, there's the potential for bleeding. So if we're able to realign things and kind of apply an internal pressure, if you will, then that may help to slow some of that internal bleeding. If we are going to splint an extremity, we should consider holding some type of traction or trying to realign the bone if necessary. Now, this is kind of a tough thing because there's some breaks where realignment's just not going to work. And especially if it's a compound fracture with multiple breaks, realignment's going to be very tough. But if it appears to you that it's a long bone that's involved, it's an isolated injury, and you can pull some manual traction and realign it before splinting, you should certainly do so. Although the challenge here is that if any of the joints are involved above or below, we can't hold that traction. So if I've got a humeral fracture, it's pretty obvious that the bones broke right through there, and by pulling traction, it's going to help to straighten that out. That's fine. But if you also feel that there may be an injury to the elbow, well, now we can't pull that traction. So anytime we do any type of realignment or traction, we have to really be confident that it's an isolated fracture and that it's not going to cause any additional damage to the connective tissues or the joints above or below. So here, this is actually a prime example where they feel that they need to try to realign something, but we have to watch out for any involvement of the joints. Yes, they're going to scream in pain as you realign it. However, usually once you do get a bone realigned and you have that gentle traction applied, they're going to have a substantial relief in pain. So they'll probably thank you for it after a while. They'll curse you for it while you do it, and then after that, they'll give you a thanks. We'll practice this more in class. I don't want to get you to try to visualize what it means to pull manual traction. These are things that we really need to practice hands-on. As far as splinting goes, there's lots of different types of splints. It lists 3 here, but in truth, there's even more than that. And what this doesn't necessarily list is a pillow splint. And I can tell you, I can count on one hand the number of times I've used a true commercial splinting device. More often than not, I simply use a pillow. I wrap the injured area in that pillow. I tape it up and just try to kind of keep it immobilized and elevated in that soft cushiony area. From there, it's not practical to put these big formal splints on all the time. You will be introduced to traction splints specifically for femur fractures this year. That's something new from First Responder. Those are very beneficial. The challenges that we have, though, with femur fractures is that it's difficult to guarantee that it is only an isolated femur fracture and that we don't have any involvement with the knee, the hip, or anything else. And the reason being is because it takes an incredible amount of force to fracture a femur. That's one of the largest and thickest bones in the body. So because of that, when there's enough force generated to fracture the femur, a lot of times we have all other associated injuries that prevent the use of that traction splint. So if we are going to splint, as always, care first of all for the ABCs. Beyond there, we should always be exposing our patient so that we can visualize the actual injury And then from there, before we do any splinting, realignment, or manipulation whatsoever of the injury, we want to assess the SMVs, CSM, whatever you want to call it, beyond the point of the injury. So we want to assess, do they have good circulation? We can look at the skin parameters beyond the point of the injury. We can assess cap refill. I can also check for a pulse, and I want to make sure, hey, can you move this? Can you feel me touching? That type of stuff. Immobilize the injury site and the adjacent joints. So what that means is that if I have a bone break, I'm going to immobilize it to the joint above and below. And if I have a joint issue, I'm going to immobilize to the bone above and below. And what that does is it helps keep everything in place and address movement. And again, this is something that we'll talk about more in class. The other thing I want to point out here, though, is padding voids. Everybody's shape is a little bit different, especially depending on fat or muscle content and everything else. So when we do apply a splint, it's not necessarily a one size fits all. We're going to maybe need to take some sheets or blankets or towel rolls, whatever, and apply some padding into void spaces behind a knee, inside of an elbow, wherever it may be appropriate. It says here, don't splint your patient to death. And all that is probably the 15th time in this discussion that we're going to remind you, make sure that you take care of life-threatening issues first prior to focusing on these nasty, gruesome wounds or injuries and addressing them. Also, we want to make sure that the splint is on appropriately, not too tight, not too loose. Again, all things that we will practice in class. All right, so long bone and joint injuries. I just mentioned it. We're going to go from the joint to the joint or the bone to the bone, depending on where the injury actually is. And we're going to realign only if appropriate. And a lot of times, if they have a good distal pulse and we can get by without realigning, we're going to leave it in place because we don't want to risk doing additional damage. This image here shows, checking things like cap refill. And you can check cap refill simply by pinching the skin on the top of the hand. You can also use the nail beds or anything else. They want to check to make sure that there's a good pulse. They'll check the radial site here, and then they'll make sure that there's movement of the fingers and that they can actually feel touching. The rest of this stuff is procedural, which are all things that we're going to do in class. So I don't necessarily want to get into that now. Let's see what else we have here that is relevant. Let's talk quick about this hockey player. So we've got a hockey player that's injured. Obviously, it looks here as though they suspect there is a femur fracture. This guy is kind of holding everything still. This woman is checking distal pulses to see if there's any circulation involvement there. They're probably going to apply a splint. Something to think about, though, is that this injury, this fracture of the femur, is going to be very painful. And not only would it be distracting potentially to EMS providers, but it could be distracting to the patient as well. So the presence of the pain coming from this femur, especially before it's splinted or anything else, could be distracting from the fact that they also got hit and they've got a liver lac, or they've got a pelvic fracture or some other underlying type of injury. So before we go and just start focusing simply on this and splinting, we should be sure that we do a good head-to-toe assessment and make sure that there isn't anything else that we're missing. This is, you'll see here she's pulling traction, and as she pulls traction, they should be preparing a traction splint before they actually get to this point here. As she's pulling that manual traction, he's measuring the traction splint to the opposite side, and he's going to then move it over to the affected injury. Why do we measure it to the opposite side? Because we want to utilize the non-injured area to set the length. They'll put that in place, they'll hold the manual traction, and then they'll wrap it up. And again, these are all things that we will practice more in class. Shoulder girdle injuries. These are very painful, but relatively simple. We're going to put them in a sling. We're going to attach the sling and the rest of the arm to the body there, just to try to minimize movement. Beyond that, though, we're never going to set a dislocation. We'll take this patient into the ER. The doctor may take 30 seconds and say, hey, hold your breath really quick, and snap, and put that dislocation right back into place. And the patient, obviously is in pain for a split second, and then they feel that substantial relief. But that is something that is outside of our scope. We will not be doing that in the field. And the same thing with shoulder girdle injuries as everything else. Assess distal SMVs, immobilize, and transport as necessary there. Pelvic injuries, now this is going to be a bigger concern. We do handle these with our elderly patients relatively often. Again, even a simple fall from standing can be enough to cause a pelvic injury. And in this situation, what we have to be concerned about is the presence of bleeding more so than anything else. Yes, this is a very, very painful injury, and the patient's going to be very uncomfortable, but we're also concerned about that internal bleeding. And because that internal bleeding is within the pelvic girdle, it's going to be very difficult for us to identify, and there's a chance that it could actually put a patient into shock. So these are all things that we have to really look at. There's a lot of indications of a pelvic injury. We'll see a shortened and rotated extremity oftentimes. And this could be from a dislocation. So if the the top of the femur is dislocated from the hip joint there, we may actually see it shortened up a little bit and rotated on that affected side. And that would be an indication of the dislocation. It could also be an indication of a pelvic injury. Unexplained pressure in the bladder from anything that's actually physically touching it, or from bleeding that would be putting pressure on it. And then any bleeding from the genitalia or the rectum there that would suggest that something within the pelvis has been fractured and has caused additional trauma. When we're dealing with pelvic injuries, these are tough. And I'll tell you, really for all of these, although most fractures are not going to be life-threatening, it would still be appropriate to contact ALS just simply for the pain management perspective, right? Allow them to come, start an IV, and administer some narcotic pain medications to try to minimize the discomfort of your patients. The same thing would apply certainly for a pelvic injury. And I would argue that a pelvic injury, because of the bleeding potential, should be an ALS-related call anyway. And in these situations here, try to keep them still. If you can leave them where they are, if they are hemodynamically stable and you're not urgently needing to move them or rush them to the hospital, wait for that ALS response for the pain management. But beyond that, try to get them straightened out. There's some pictures coming up here that I think do a nice job of really showing us how we can prepare. So this is a pelvic wrap. It's a commercial device. Nobody carries those things. This is what we have. We have a sheet or a blanket. We're going to fold it up this way. And what we want to do is we're gonna get probably 6 people at least on this poor little old woman here as we move her onto the board. Now, because of the pelvic injury, doing a log roll, it's not really practical, right? So we're going to get a bunch of people to kind of get underneath the legs, to stabilize and get underneath her hips, underneath her back, somebody to hold her head, and we're going to gently lift her up and slide the board underneath, okay? And as we do that, once we get her onto the board, now we're going to take this sheet, we're going to wrap it around, we're going to kind of wrap it around and twist it, and then we're going to be able to pull tight. That inward pressure, that ability to kind of squeeze it all together, kind of prevents some of the crepitus from any of the fractures within the pelvis, and it's going to offer a little bit of relief, and it should help us minimize some of the bleeding internally. Hip dislocations I just mentioned, right? Whether or not it's anterior or posterior, we're not really going to be confident, but we can look for that shortened and rotated extremity, and obviously pain and lack of sensation, because the nerve endings and even the blood vessels come right through that joint there. If it's dislocated, those could be involved. Let's see here. For just hip dislocation, even though we're not immobilizing for C-spine or general spine precautions, we're going to put them on that backboard simply for movement, to make our job easier and prevent us from having to move that lower extremity around. We talked a lot about our geriatrics already. We talked about these hips, so I think we're good there. Femoral shaft fracture, these are the things that are going to necessitate the traction splint, and we'll practice that in class. We talked about that with the hockey player. Knee injuries, they're going to hurt, obviously. We're going to want to immobilize that in the position found. Obviously, if we have a joint that's involved, we don't want to manipulate or move the joint at all. So if their leg is bent and that's a position we find it, I'm probably going to pad beneath the knee itself. I'm going to take a long rigid splint and I'm going to run it from the femur all the way down to the lower parts of the legs, and probably do it on both sides, and again try to immobilize that knee. I know that's difficult to picture, which is why a lot of this stuff is better taught in class by actually doing it. And the same is going to apply for all this stuff. Ha! Here's your pillow splint. Best splint ever. This right here, if you're riding on an ambulance with me, this is going to be what we do 99% of the time. And I think that really takes us to the end, because everything else is the exact same. We're going to spend a lot of time in class actually going through and practicing all these different types of splints. We'll challenge you. We'll put some patients in weird manipulated positions, see how well you can actually splint things up, see how well you can immobilize, and then we'll go from there. So kind of a short chapter, down and dirty, to the point though. I hope you enjoyed it. We'll see you in class for a lot of hands-on practice.